Hello everyone, here is Dr. Ahmed Aly Elyan, Perfect Dent Operation Manager. Today we will continue our event, Meet the EdgeEndo Experts event with the second webinar. If you didn't attend the first webinar, you will find the link in the comments of the Facebook. Please don't forget to write your names in the comments to have the chance to win a 5,000 Egyptian pound voucher from Perfect Dent. First, let us together remember what happened in the first webinar. Hello everyone, Ramadan Kareem, Dr. Ahmed Elyan, Perfect Dent Operation Manager. We are celebrating the online launching for one of the best files in the world, EdgeEndo files here in Egypt, with Dr. Mohammed Ala Fakhr, Professor Gianluca Gambarini, live from Rome, Italy, Dr. Mohammed Abd El-Rahman.
An inability to manage and curve can result in a ledge, apically.
What is very important is that you have to decide actually how complex is the situation, how complex is the curvature.
Which file we are going to use to solve all the problem.
Design affected all the properties of the nickel titanium rotary files. Heat treatment now has become a major feature in determining night eye performance.
As the degree of the root canal curvature increases, the amount and volume of the irrigant reaching the working length down there decreases. So sodium hypochlorite should be used instead of paste lubricants when using naked titanium files.
I have to pre-curve my initial file or my patency file. If you took the lens before the coronary B flaring, you'll end up by an over instrumentation.
My recommendation is avoid using larger taper files more than that.
And we call it Minarachi. What is Minarachi?
Would you use the master cone? Would you use 25.042 with the bioceramic sealer and that's it?
What about C+ files in such curved canals? Thank you all for watching. Goodbye.
Thank you. Goodbye.
Ciao, ciao.
Yeah. Bye-bye.
Okay, it was a great webinar full of tips and tricks on how to management curved canals using edge files. Okay, today's webinar will be minimally invasive approach, and we will start our webinar with the first speaker. Today is Assistant Lecturer of Endodontics, Azhar University, Dr. Abd El-Rahman Ali Hamouda. Hello, Dr. Abd El-Rahman.
Hello, Dr. Ahmed. How are you?
How are you? Ramadan Kareem.
Fine. Ramadan Mubarak.
It's all about 5 days, and we will finish this great month.
Yes.
Okay, Abdurrahman, as I said, the first webinar was managing of canal curvatures, and today webinar will be minimally invasive endodontics.
Yes.
So you have here an interesting lecture title, which is Minimally Invasive Canal Shaping Between Fiction and Reality.
Yes.
I think it will be...
we will brainstorming about the minimal invasive in endodontics at general, yes.
Okay, I think we will enjoy it. Okay, are you ready?
Yes.
Okay, let's go. I will join now the audience and enjoy watching this lecture.
The share screen is okay, Dr. Ahmed?
You can start. You can start, Abdurrahman.
Okay. First of all, I'm honored to invited by Perfect Dent Company to with an interesting webinar with Professor Gianluca Gambarini and Dr. Ahmed Aly Elyan and Dr. Nader Ramsis. Today, I will talk about minimally invasive in endodontics, and we will brainstorming about approaches, techniques, how to be minimally invasive during doing root canal therapy. There is no doubt that successful root canal treatment, depending on the first place on diagnosis, treatment plan, and case selections, anatomy and morphology and access cavity preparations, how to do 3D cleaning or biomechanical preparations of complex root canal system, and 3D obturation and coronal seal is one of the most important steps during root canal treatment. But the main objectives of root canal treatment are complete elimination of the bacteria from complexity of the root canal system and prevention of reinfection treated endodontically treated teeth, and the most important goal to preserve structural integrity of dentine as much as we can. So, to preserve the structural integrity of dentine, we will talk the first on the minimal invasive and access cavity preparations, and how to be minimal invasive during canal shaping. Chapter 1, minimal invasive and access cavity preparations. There are a lot of ways to reinforce the tooth structure through the access cavity design, and the first spark was started by Clark and Khadami in 2010, when David Clark described the modified conservative access cavity to minimize tooth structure removal. Clark described the first term, which is pre-cervical dentine. Pre-cervical dentine is about 10 millimeters of dentine at the neck of the tooth. It's 4 millimeters of dentine above the crestal bone and 6 millimeters of dentine below the crestal bone. If we save the pre-cervical dentine as much as we can, we increase the longevity of the tooth structures for long term. A lot of literatures talking about to be minimally invasive in access cavity preparations. One of the most interesting articles by Professor Marco Martigoni and Simon Grandini, comparing between traditional access cavity and conservative access cavity and truss access cavity, and they found that traditional access cavity preparation didn't improve fracture resistance when comparing with conservative access cavity and truss access cavity. Another interesting article done by my colleague Mahmoud Yahya Abu Naga and my professor Mu'taz Billah Ahmed Al and Professor Ashraf Rifai, which comparing the MOD cavity, truss access cavity and MOD cavity and traditional access cavity preparation, they found that truss access cavity improve fracture strength of tooth structures when comparing with traditional access cavity and MOD cavities preparation, while artificial truss restoration with not significant difference in fracture strengths. Also, another interesting article done by Professor Gianluca and Professor Gianluca Gambarini, comparing between traditional access cavity preparation and conservative access cavity preparation and ultra-conservative access cavity or ninja access cavity preparation. The conclusion was teeth with traditional access cavity show lower fracture strength when comparing with conservative access cavity and ultra-conservative access cavity, but the ultra-conservative access cavity didn't increase fracture strength of the tooth comparing with the conservative access preparation. I was honored to meet Professor Gianluca Politino in 6th Arab Morocco last year and talking a lot about minimally invasive in endodontics and his interesting techniques, intraoral stepwise activations. The arguments. Helfer argued that tooth structure become brittle due to loss of moisture, which is about 9%. But the fact is, the tooth become brittle due to lost amount of tooth structure during shaping and not during dehydrations. Studies showed that minimal dehydration effect from the pulpal removal with similar strength test result between vital and non-vital tooth. Again, the minimal invasive in endodontics is a package. I can't take one of this package and leave the others. I need magnification, dental operating microscope or a dental loop. I need to be conservative. I need ultrasonics. I need methods to activate the irrigation to ensure that irrigant will be touch almost the wall of the canal. I need device to allow thermo plus size technique gutta perca to reach to seal the complex of root canal system. And in some cases, we needed ComPMCT, not in all cases, but in some cases, we need CBCT to doing some minimally invasive in endodontics. Quick home messages. Access cavity, one of the most important key in successful root canal treatment. Conservation of the tooth structure is the best and the only proven method to support the endodontic quality teeth. Clinicians should adapt their skills to meet the challenge of working in confident space. Chapter 2, I will talking about minimal invasive in canal shaping. We have the arguments. Number 1, minimal invasive access cavity allow for us to deep cleaning and shaping or not. Number 2, it's necessary to remove more dentin to allow deep cleaning or 3D cleaning. Let's back to 1974, when the children putting the objectives of root canal treatment, biological and mechanical objectives of root canal treatment. The concept of cleaning and shaping biomechanical preparations has modified during the years till we reach to the most recent concept, which is shaping for cleaning. Minimal shaping of the canal that allow us for make 3D cleaning of complex root canal system. We don't need to shape the canal more than that. The endotriad shaping of the canal to allowing for irrigation to go deeper to the apical area or to apical third and penetrating the internal tubules to eradicate the bacteria or the bacteria biofilm from the complex of root canal system, and after that sealing the 3D complexity of root canal system by 3D filling apically and coronal and middle third, and apical, lateral, and coronal. The way of success is depending on the size of triangle, access cavity, shaping for cleaning, and obturations. All steps depending or interdepending to each other. Not one are important than each one. Access cavity, it's important to allowing for us to go shaping, and shaping allowing us to go deeper for cleaning, and 3D or flow tight seal or hermetic seal of complex root canal system. But when we're dealing with the canal system, we're not dealing with the canal. We're dealing with root canal system. We have complexity when we're dealing with the root canal system, apical ramifications, fins, anastomosis between the canals. So we have the challenges. The challenges when we're doing root canal system. First, the challenge when the microbial content in the complex of root canal system. The bacteria in the canal, the bacteria not only on the canal, the bacteria on the canal walls, and the bacteria have two forms: planktonic form, which is easy to remove by irrigations, and had another aggressive form is called the bacteria biofilm. Mass of the bacteria adherent to each other and excrete external polymeric matrix, which resists the most of antimicrobial agents. Second, the challenge, we have morphology, anatomical variations of the root canal system along, especially in the apical third, but along the root canal system. This anatomical variation, one of the challenge to how to deep cleaning in these variations, anatomical variation, and how to fill these spaces. The third challenge, the files, either rotary or manual files, didn't touch almost the canal wall. According to Peters et al. In 2014, the maximum touch of files to canal is about 65 or 70%. The remaining 35 or 30% is untouchable area. So depending on the irrigation, the methods of delivery to irrigations, activation of the irrigation by either sonic, ultrasonic, or whatever the methods of activation to allow the irrigant to go deeper in the canal and eradicate the bacteria from complexity of root canal system. Regarding to shaping, the alloy advancement through the timelines, in 1900 it was first use of stainless steel rotary instrumentation, and in 1950 to 60 the discovery of nitride alloy. In 1970 to 80, revival of use stainless steel rotary instrument, and in 1980, while Italy used the first manual instrument, nitride, and in 1990, combination of rotary nitride and a lot of technology to date, development of different rotary nitride alloy. One of unique properties of nitride, shape, memory, and super elasticity. the file can be returned into original position. It's a good point, but in curved and severely curved canal, some sort of zipping or transportation can be done. So that's unique property of NiTi shape memory. The clip can be returned to its original position. But when we're dealing with curved or severely curved canals, we need minimally invasive preparations, and we're doing CM files or controlled memory files to allow shaping. The concept of deep shaping previously to large diameter, or the canal shaping the canal to large diameter to allow the irrigant to reach to the apical constriction or the apical third. It is done preferable in curved or severely curved canal. This case referred by my colleague. Actually, he prepared the mesa root till file tip size of 0.40, and the patient has repeated swelling in this area. The patient, when referred to me, send him to make a CBCT. CBCT, one of the important steps when diagnosis, and if we're facing a problem with the patient, showing through the axial and coronal and sagittal view. Here we go. In the cross section, I found the vertical root fracture here, and in axial also we found the cracks extended the vertical root fracture. So excessive taper in such severely curved root, it ended up by vertical root fracture or cracks extended to vertical root fractures, and at last the tooth will be extracted. So in such cases, I prefer to using CM files, controlled memory files. One of unique files which work perfectly in my hand is Edge file X7. Edge file X7 have unique property. It's made from 5-wire NiTi alloy. The shaft is flexible, which allow to be minimally invasive in preparations, or when I made access cavity small as much as I can entire file from small orifices or small access cavity to go shaping of the canal. The files also is electropolished with increased strength and sharpness of the file. Available from taper 4 and taper 4 and taper 6. Tip size starting from 0.70 to 0.45, and the flute's diameter maximum 1 millimeter, which allow us to be minimally invasive in preparation. Simplified technique, using 10 file to scouting or to making glide path, 10 file, 50 file, 15 file. After that, I go using 4 file 0.70 and maximum in straight canal 25.4 or 25.6 at torque at speed of manufacturers. But in some cases with severely curved or minimally curved canal, I go using for the glide path files, edge glide path. Edge glide path is the game changer files, have tip size 0.19 and variable taper, triangular cross section, also made from 5-wire NiTi alloy, which increasing the flexibility and strengthening of the file. Before I using the glide path, edge glide path, I using 6 file, recurved file, till the file become loose in the canal, 10 file and 15 file. But with the game changer files, edge glide path, I only can use file 10 to be completely loose in the canal, and I using the edge file and stepwise interoperative activation technique. Stepwise interoperative activation technique, I first heard from Professor Gianluca, which between each files, I make an irrigation, filing, irrigation and activation, and using file again, irrigation and activation, and so on. It's allowing the irrigant to maximum touch all of the canal wall, especially the untouchable area, and allow removing the smear layer of the canal and debris from the canal and debris almost during the shaping. Again, stepwise interoperative activation, file, irrigation and activation, file, irrigation and activation, reaching to master apical file. So In management and severely curved canal, my protocol, I using 10 file. After that, I using the glide path files. So after that, I using edge 25 taper 4, and in most of the canal maybe reach to tip side 30 large canal. And in curved canal or severely curved canals, narrow canals, I end my preparation at 0.5 edge 25 tip size or taper 4 or taper 6 according to the canals. Here we go. We discussing some case reports and showing how dealing with such of the curvatures and the minimally invasive. Case report number 1. Root canal treatment of lower wisdom with severely curved canals. The patient came to me with severe pain. The diagnosis with symptomatic irreversible pulpitis and the access cavity. The caries was the mesial wall only. By reading the preoperative X-ray, I asked myself why I didn't save that lot of dentine and making access cavity only through the mesial wall, especially in the preoperative X-ray, the caries in the occlusal is seeing in the enamel only, not in the dentine, not penetrating the dentine. So I have caries in mesial only, and I can do access cavity from the mesial with trends and the flexible file like edge file. I can finish my preparation safely. The access cavity was done only from the mesial side, and the caries and the occlusal was removed later on. The working length was determined, and the multi-planar curvatures, we have triple curvatures in such roots: first curve, second curve, and the third curve. Master cone was done in file preparation was done in the mesial root till 25.6 and in the distal root in file 30.4, and the master taken, and post-operative X-ray showing lateral canals in the distal wall and massive amount of dentine I be saved in such case. So the patient didn't need for crown, just follow up X-ray after 3 and 6 months to follow the case. Case report number 2. Non-surgical retreatment case of lower 4 with deep apical split. Analysis of the pre-operative X-ray showing short filling and deep split here in the canals, buccal and lingual canals. The cataperca were removed with rotafiles, and scouting of the canal was done file 8, file 10, and file 15 K file. The canal shaped with file 25 with file 20 taper 4 and file 25 taper 6 only, and activation and irrigation of the complex root canal system was done till we found final irrigation protocol. After that, post-operative X-ray showing minimal invasive canal shaping here and saving a lot of precervical dentine, as we mentioned at the beginning. This is the full case. Case report number 3. Lower 7 with symptomatic apical periodontitis. The patient had leakage from the crowns. I removed the bridge and starting to doing my access cavity. My access cavity was minimally invasive and trying to scouting the lateral canal, and I did in this case. Master cone was done. The preparation in this case ended by file 35.4, and here we go. There is access cavity, the blue lines only, and the red lines is saved dentine. I didn't need to remove it to go for root canal treatment, and we found such apical amazing ramifications or multiple portal of exits. So I can't need to remove much dentine to allow deep cleaning or 3D cleaning, just how to reach your irrigant and activate your irrigations. Last case, upper 8 strategic tooth. Preoperative radiograph of the upper 8, the patient referred to my clinic. The patient upper 8 was used to abutment under the bridge. My colleague tried to open the access cavity, but unfortunately he didn't, or he couldn't find any canals. So referred the case to me. Access cavity was refinement and the pulp stone or calcification was removed by ultrasonic. I found the mesobuccal and distobuccal and the palatal canal. The mesobuccal and distobuccal canal were severely curved. I negotiating the canal starting from file 6, 8, 10 file K, and then using the glide path files, edge glide path to making micro reproducible glide paths. The masker cool was taken. The preparation was done till file 30.4 in palatal and file 25.0.6 in mesobuccal and distobuccal canal. Post-operative X-ray showing lateral canals or in the palatal canal and in mesobuccal also and distobuccal canal, allowing good shaping through the minimally invasive access cavity was done here, and the curves in the distal side was sealed with composite restorations. This is full case. Recently, by conservative approach, there are conservative techniques in biomechanical preparation called non-instrumentation technique by device called gentle wave. The gentle wave device, when using it, only we do access cavity preparations and putting the handpiece above the access cavity. The gentle wave will suck out all the content of the complex root canal system. Debris, small layer, pulp tissue, vital, necrotic. After that, we're sealing the canal with calcium silicate sealer or with thermoplasticized gutterwork. One of the futures of in endodontics, gentle wave, the researchers done in this field to allow using the device in our practice, but the device is costly, not easy. It's about high price. How long does it take to acquire new skills? It's about learning, practice, learning, and practice and repeat. That's my personal contact. If anyone need to ask or to send to me, you are welcome. Thank you, Dr. Ahmed Elyan, and thank you, Perfect Dent Company, for hosting me.
Okay, thanks, Abd El-Rahman, for this lecture. I think it's a very magnificent lecture. A lot of difficult cases, but you manage it very well, especially the lower 8. I think we will have a lot of discussion about this lower 8.
Yes.
But we will have problems with this fixed orthodontics because you said that you didn't put a crown. Okay. Okay, we will have the discussion for this case at the end. But for anyone who is joining now, we would like to announce that you will find the products of Henry Schein products here in Egypt, just Perfect Dent. Not this surprise only, but we have a lot of surprises soon. Now we will join with Professor Gianluca Gambarini from Italy, Rome, live, but after this report about him. Hello, Professor. Hello, Professor Gambarini. Hello, Professor. Can you hear me?
Yes, can you hear me?
Yeah, we hear you very good. Here is Dr. Abd El-Rahman Ali Hamouda, Assistant Lecturer of Azhar University.
Yes, I follow the lecture. Here I am. Yeah.
Hello, Professor.
Hello.
Great, Professor. Here we meet again in the second webinar of our event, Meet the EdgeEndo Experts event. Today's webinar is about the minimally invasive approach. And
yes.
now,
so hello.
Yeah, well, we can hear you, Prof. Yes.
Okay, perfect. So we can start, and it's my pleasure to come back again and speak about endodontics, which is the things I like quite a lot. And thank you for the invitation, and thank you for choosing this interesting topic. Because there's a lot of misconcept about what to do and how to do things, but we should think about there are some important issues. First of all, actually, we are speaking mostly about shaping today, shaping strategy, and obviously cleaning and obturation goes together. But the most important thing is to understand the anatomy, because if you don't really understand the anatomy, it's not easy to understand what we are saying. So what we did in the last 10 years, we have been extensively used clinically cone beam, trying to understanding the anatomy and try to find the right strategy for each case. This is quite an interesting and innovative concept, and because what happens in the reality, what we have on a traditional radiograph, two-dimensional radiograph, is not the real anatomy. So we have the clinical view, which is the traditional view, but also we have a hidden mesial distal view, which is the CBCT view. And if you see the two canals from the different view, they may look similar, but they may be very different. So this means that the different anatomy may create a lot of problem or may increase a lot of instrumentation stress and may cause a lot of iatrogenic errors because we don't understand the trajectories and the anatomy. So we have curvature that we see, but also we have a lot of curvature that we do not see. And this is the reason why we have to think. And we have to think why things sometimes do not go as smoothly as we think. For example, in this case, we have two in yellow. They look quite similar, but if we start instrumenting them, we will find it out that this is the three-dimensional anatomy. These are the hidden curvature. We have a lot of multiple and abrupt curvatures. And this is very common in molar cases, and this is why molar are so complicated. And this is the reason why we need some special files. So we know from the 3D anatomy that the canals are more curved and complex in 3D, and we need, therefore, more flexible instrument. We know that the three-dimensional anatomy, it's more stressful for the instrument, so we need more resistance for the instrument. We know that the canal shape is not round in 3 dimensions. So that's a very important thing we have to understand. And last but not least, the majority of root canals are oval. They're not round. Now, this is an interesting point because all the speakers always heard proposing a technique or proposing something new. Let's do this, let's do that. Actually, they never thought in 3D. They always thought in 2 dimensions. Now, this is very important. The same, when you see a canal, you may see like this, or you may see like this, which means is that we are seeing the canals from a different perspective. So when we have an oval canals, we never have one taper. We have at least 2 taper, one small, 2 or 4%, and one is a big one, usually 8 or even more. So what does it mean actually? Is that in most of the cases, we have taper already. And especially when we have oval canals, we already have taper. So our strategy is not to, create a taper to improve irrigation, just to create taper to make our instrument go nicely to the working length and bring the irrigant with them. So that's a quite interesting thing to see and to say. And this is why last time I spoke about the new files, the X7, and I show a very, very simple sequence using only 2 night-eye rotary files, 1704 and 2504. And everything that you see today is done by only 2 files, which are minimal invasive files, because they are very small diameter. Maximum diameter is 1 millimeter, and they are martensitic file, extremely flexible and resistant. So last time I showed you how these instruments were so good in the apical part, and this is very easy to understand. Now I will show today how these files can work very nicely also in the coronal middle part. And the interesting thing, as you will see, is that you will see this kind of anatomy, and you will see this, that the anatomy is very nicely respected, but the canals are also in a certain way shaped. And so we have to define what do we mean when we speak about shaped canals. And this is a very interesting issue. So the very important thing when we deal about the instrument actually is obviously the design, is obviously the manufacturing, the heat treatment. And I spoke last time about the importance of the EdgeEndo firewire heat treatment that makes the instrument the most flexible and the most resistant on the market. But very, very important is also the clinical use, the motions, and the strategy. Now, I explained last time a little bit about a technique to reduce instrumentation stress in the apical part, and this technique also improves a lot irrigation. So I totally agree about the importance of the irrigation, and actually my technique is the technique that we bring more irrigation than any other technique. But on the other hand, we have to define a few things. For example, when we do small access cavity, we have to be aware that there is a balance between the interference and the resistance of the instrument. If you use martensitic file that you can pre-curve like the X7, you can try to do smaller access cavity because the instrument will be less affected. But I will not recommend to use traditional night-eye instrument and making a very small cavity if the canal is not straight or very little curved. But what is very important that you have to understand is that you have to use the instrumentation in a different way. You have to change the way of thinking and using the instrument. So every night-eye instrument is theoretically a reamer, because it works into the canal with a reaming action. And this is where we have to be very careful. We have to go step by step with the Mimerachi technique I explained you last time, and very slowly, very carefully. And this is the phase when you go to the working land where you can make all the mistakes. You can make ledge, you can make transportation, you can break the instrument and everything. But when you are at the working length, or when you are at your working length, what you can do, you can also start to use this instrument as headstone file. So using them by doing filing, circumferential filing, brushing, filing only on one surface. This we practically call it brushing, and it's so interesting because there is a huge difference between the two motions. When you go in, when you work in, this is a very stressful instrumentation technique. When you're working out, when you're doing brushing or selective or circumferential flaring, you are actually not damaging, not stressing the instrument at all. You can even increase speed, you can increase torque, whatever you like, and you can cut, if you want to cut, in a much more efficient way. So actually, what we should think that especially in the coronal and middle part of the canal, we have to take advantage of this possibility to make most of our shaping not in a working in, but in a working out method, which is much safer, much more performing. Now, obviously, when we speak about shaping, we also speak about cleaning. But there is a big difference when we speak about cleaning is between cutting walls and touching walls. What we have to do is not cutting too much the canal, is touching canal walls to remove bacteria, to remove biofilm, to remove tissue left inside. So since we have a round instrument, when we have a round canal, we can do quite little circumferential filing. But still, I would recommend to improve bringing the irrigant inside the canal. But obviously, when we have a little bit more oval canal, we have to increase the amount of circumferential filing we have to do. And when it's elongated canal, we have to do this kind of circumferential filing much more extensively. But once again, we don't want to cut too much dent in here. We don't need to cut. We need to touch the canal walls. This for the cleaning. This is very important. This is for the cleaning. So the amount of brushing depends on the anatomy of the canal. And this is very important that we should understand. And obviously, our instrument is round. And when it goes inside the canal, it may find some friction because it touches two canal walls. But actually, we have to move it all along and try to touch more canal walls. So practically speaking, by moving the instrument and touching all the canal walls, we clean the canal much better. We help the irrigants to reach all this part inside the canal. And obviously, we have this very nice shape in our three-dimensional final radiograph. So nowadays, I think that this kind of approach, working in and working out with the brushing, is not optional. It's a must-do. But very interesting. This kind of approach is very useful for shaping purpose, to reducing instrumentation stress, to reduce iatrogenic errors, and also to make our life easier, to make our preparation faster. So the interesting thing is that when I use the instrument, let's say I'm using an 0425, and I do some brushing, what happens? I no longer create a 0425 canal. I can create a bigger taper. We have flare more. So it's no longer a 0425, it can be a 0525 or 0625. So practically speaking, I can decide the amount of taper I want to create, if I need, only by doing more or less brushing in a very safety way. So this is also very useful because I can do all this kind of very nice shaping using only two night-eye rotary files, and this is what I do. And obviously, if you brush with the first file, that creates a lot of difference. That makes life much easier for the second file. So once again, in my hands, this is no longer an optional technique. This is a must-do, because if I do this with no cost, with no risk, I can increase quite a lot the performance of my files, the safety of my files, and also the durability of my files. So this we did quite a lot of testing and work about this. This is an article published on the International Endodontic Journal about this. because we did all measurements in vivo about this kind of technique. So everything I'm saying is a little bit evidence-based. It's not only based on my technique. Now, minimal invasive endodontics, for me, makes no sense. What in my opinion makes sense is rationally invasive endo. So you have to rationally think whether you have to enlarge the canal, whether you have to flare the canal, and whether you do not have. So in my opinion, and this is what many dentists do, but they don't really understand this, you only need to make curve easier by reducing the interference. Your instrument must go to the working length without iatrogenic errors, easily. And if you do this, then you can clean, brush, you can do whatever you want. So the amount of the three-dimensional, I'm speaking about three-dimensional coronal flaring, in my hands, depends on the apical curvature. So the more complex is the apical curvature, the more flaring, the more straight line effects is needed. Not because I don't want to overstress my instrument. So when I have a case like this, when I insert my instrument already flexed, I can even pre-curve my Martin CD file, but actually I understand that I have a very coronal curve, and why I probably, if I have a very good instrument like E7, I could manage to do this. But why? Why should I run this risk if just only by slightly opening a little bit more my access cavity or my coronal flaring, I can do this? But I have to understand what I'm doing, and I understand why I'm doing. This is a very dangerous curvature because it's a long curvature, and if you don't use the right instrument, but if you don't use the right strategy, you may fail here very easily. And this is why sometimes you see these weird cases of broken instrument in the coronal and middle part of the canal. It's not unexpected fracture. It's because we don't understand the anatomy. So when we insert files with big angulation, when we create abrupt coronal and middle curvature, that's impossible for the night's eye than to go and instrument the apical part. So actually, we have to manage and play a little bit with the curvature. We cannot play with the apical curvature. We can play with the coronal and middle curvature. How can we play? Well, what we can do actually is what I call selective coronal flaring. Why it's selective? Well, I will explain you later. It's a coronal flaring because when you do coronal flaring, practically speaking, in terms of biomechanics, you use the angle and increase the radius of the curvature, so you make it easier. You shorten the length of the curvature, so you create less stress. You eliminate and reduce the coronal curvature. Once again, less stress. So you make life easier for you and for your instrument. And you make way less iatrogenic errors. But you have to understand the principle here. So the principle of this is the anti-curvature method that was defined years ago by Aburas and Piccinino. But actually, this is no longer, in my opinion, valid, because this was a two-dimensional flaring. Now, when you have a molar case and you have this kind of a curvature, you have to think differently. So the flaring, when you need to do the flaring for shaping purpose, I'm not speaking about cleaning purpose. For cleaning purpose, actually, you don't have to cut anything. You have only to touch the canal wall. But when you have to do the flaring for shaping purpose, you don't need to touch 360 the canal. You only need to cut selectively. And where do you cut? Well, for example, in a molar case like this, you have to cut mesial, and also you have to cut buccal, because there is also a buccal curvature in the coronal part. So if you want to do selective three-dimensional flaring, you have to cut 180-degree mesial and buccal in your canal. And that will make much, much easier your penetration of the instrument to the working length. And if you do like this, actually, this is three-dimensional obturated canal, everything will be easy. The irrigation will be much more easy and effective. The obturation will be much easier and more effective. And as a matter of fact, we were speaking before about Sonendo, but actually Sonendo needs at least an 0420 preparation. So actually you still need a proper preparation, even if you use a very innovative technique. So having said this, I am only using two instruments, 1704 and 2504. Why? Because in my selective flaring, I may use an orifice opener. Well, sometimes when the canal is straight and I'm a little bit lazy, I use the orifice opener, I must admit. But the risk is that when you are using an orifice opener, you are working in. So that could be very dangerous because you are using a file with greater taper, and you may create some iatrogenic errors. You may even, demolish too much structure. So this solution, getting inside with a greater taper orifice opener, I don't like. What I do, actually, I'm using a very small file, the 1704. I insert it to the middle of canal, and then I start doing selective flaring. So I'm doing flaring with a very small taper flexible file, very gently, and I need only to flare the minimum to make middle and apical curvature much easier for the instrument. And usually I'm very conservative while doing this, and then I use the next instrument, and if it progresses easily, I'm fine. But if the second instrument does not progress easily, I go back with the first, flare a little bit more. So my decision is based on the anatomy only. So that's why I'm saying it's rationally invasive. So when I have not a very complex situation in the apical part, I don't need to enlarge at all. I don't need to do selective flaring. I need only to touch all the canal walls. I do only circumferential filing, very gently and little. I'm not cutting, I'm touching. But also you have to understand that sometimes we also have hidden curvature. This is a very typical case, an instrument fracture in the middle part of the canal. And the reason why, because there was an hidden curvature. So when we have this hidden curvature, we have to deal with this curvature before going to the apical part, because otherwise they will create too much interference and too much problems to our instrument. And once again, it is exactly the same. To deal with this curvature, you have to slightly increase the coronal and middle flaring using a very small instrument and flexible, and moving it out from the canal with a selective flaring motion, with a working out. And then you will see that you do a very nice cases with a rationally invasive approach. And this is actually what I do. And this is why I don't need many instruments, I need only two. This is why if I want to create more selective flaring, I use the instrument more in the working out. This is why if I get quite easily to the working length, I actually don't create any taper. I only create the taper in 3 dimensions. This is very, very important to understand, only when I need. So the general rule here is if you need your instrument for better cleaning, you only have to touch the canal walls, not cut the canal walls. If you need to shape a little bit different the canal, then you have to cut, and you do with the selective flaring. And obviously you have to understand that the apical curvature, sometimes you see, sometimes you don't see. I showed these cases last time, because this is actually, it was a great case, and it was a great case because we are using flexible Martin Citix X7 that were so good at instrumenting that hidden curvature. But if you see that case, you may see that that curvature, but also the one in the middle, were very nicely instrumented because there is a straight line as sex from the orifice to the complex beginning of the curvature. That allows the instrument only to be stressed in the apical part and make no iatrogenic errors. This is why I'm not saying that these are all piece of cakes, but by using a very flexible and resistant instrument like 6-7, an instrument I can also precurve, my life is way, way easier than it was in the past with a different instrument, more rigid. So to summarize, what we have to do, we have to be rationally invasive. We have to modify the curvature, slightly modified or modified a little bit more, depending on the anatomy. The more complex is the canal, the more my suggestion is to modify it, because I don't want to run the risk of making iatrogenic errors. I mean, I could even be more minimally invasive, but sometimes there's no real issue in this. And especially if you use a very small file to brush and to flare, it's very, very, very rare. I never create any stripping. If you use an orifice opener, if you use a Gates Glidden, in this case, you may run the risk of doing an orifice. To do a little bit risk of reducing the cervical depth or the cervical diameters in the dentin. So to summarize, we have, I usually try to modify the coronal curvature, sometimes also the middle curvature, to reduce bending stress, and this I do by the selective flaring. I try to do in 3D, and I hope you really enjoy this concept. If you try this, you will see how good it is. And also, I explained last time, I tried to reduce the torsional load by progressing by step to irrigating more fluently. I showed last time with the data, with clinical data, that if you irrigate not even every instrument, but every single step in between the instrument, the torque, the instrumentation stress are much lower. But it's not I'm saying this, I'm proving this. It's a different thing from other technique. So I need to increase taper if I need, and obviously I need to brush if the canal is more elongated, and I don't hurry. I first enlarge the coronal and middle part, and then I leave the complex apical shaping at the end. And the reason why I do this, because the apical curvature, I cannot modify it. I have to take it as it is. I can play a little bit with the motion, with the motors or whatsoever, but still the curvature will be there. And obviously, what I'm doing, I'm selecting the Martensitic 04, flexible, bendable, resistant file, reducing less torque. I didn't put the slide here because I put last time the slide about going from an 04 to an 06 preparation by using two instruments. You are creating a little bit more stress. If you make an 06 preparation by doing a little bit more brushing with the 04, it's way safer. And once again, this has been demonstrated. And obviously, at the end, this is what I like. At the end, number 6, I'm using a minimal invasive obturation technique. I don't want to enlarge my canal for post. I don't want to enlarge my canal for obturation. And to put a plugger, I want to use a very conservative obturation technique. And this is why I'm using bioceramics called instrumentation technique. I think I'm done. I was on time, and this is my Facebook and my email if you have any question. Thank you.
Okay, thanks, Professor Gambarini, for this lecture. As you promised us to answer the question the last week about ending your preparation with 25.4 and simplified technique plus 3 files. It was a great answer.
Yes, well, no, okay. You can do things with a lot of instrument, and that's good. Everyone uses his own techniques. Obviously, the more instrument you use, it takes more time. It takes a little bit, in a certain way, more risk sometimes, because you stay more time inside the canal. But what I was saying today, actually, there's a huge, it's not the amount of time you are staying inside the canal with an instrument, is the way the instrument works. If it works when it's getting in, it's very dangerous. If it works when it's getting out, it's absolutely no dangerous. So I may use the instrument for 3 hours, and there will be no breakage, no deformation, no damage. So it's the concept that makes the difference.
Okay, yes, if you have the guidelines, have to use your files and your estimates, it's gonna be easy.
Yeah.
Okay, as I said last week, any endodontist can see your lecture, professor, and take it as a guideline for his daily work in endo. It will be very helpful. Thanks, Professor.
Thank you.
Thank you, Professor.
Okay, let us be with the last speaker for the event and for today. One of the old EdgeEndo warriors here in Egypt, assistant lecturer of Egyptian Russian University, Dr. Nader Ramsis. Hello, Nader.
Hello, Dr. Ahmed. Thank
nice
you, Dr. Ahmed, for the introduction. I would like to thank Professor Gambarini for this amazing lecture. I really like your term, rationally invasive endo. And thank you as well, Dr. Abd El-Rahman, for your impressive cases.
Thank you.
I hope my presentation would be as useful as yours.
Of course, Nader, it will be.
Thank you. Give me a second.
Your lecture will be finding the right balance between too much and not enough.
Yes, exactly.
Okay. Are you ready? You can share your
Yes, I am
screen
ready.
now.
Okay. So can you see my screen now?
Yes, you can start.
Okay. I would like first to thank Perfect Dent for this amazing opportunity to be in the same platform with such amazing endodontic stores. Some of them are my professors, some are my colleagues. So thank you, and I can be more proud to be in the same live chat with Professor Gianluca Gambarini. Maybe it's our first time to chat live, but it's definitely not my first time to mention your name. Because actually my thesis study was about postoperative pain, and I cited a lot from your enormous studies on postoperative pain, and they were of great help. So maybe it's a good time now to thank you. Speaking of my thesis, I was lucky enough to be using the EdgeEndo rotary system in my study. So I am proud to say that I have about 5 or 6 years experience using the file. And the truth is, it never failed me. So jumping into our topic, finding the balance between too much and not enough. Again, what's the idea behind minimal invasive endodontics? We always have to put in our mind our goal of endodontic treatment. The goal of endodontic treatment is prevention or treatment of pulpal pathosis, along with the long-term retention of a functional tooth by preserving its structural integrity. And now, with the recent advances in optics and instrumentation, we can provide a minimal invasive approach. So basically, being minimally invasive is to provide a proper root canal treatment with the least amount of tooth structure to be lost, and that can't happen without proper armamentarium. We will be talking quickly about components giving us the structural integrity of the tooth, and then the different strategies for minimal invasive approaches, and then the conclusion. So again, we will repeat quickly the basic components that we most care about during tooth preparation and we most care about to preserve. Number one are the tooth marginal ridges. It's really important because according to access openings alone have only 5% impact on the tooth stiffness compared to any restorative preparations that remove the tooth marginal ridge, such, for example, this class 2 cavity, which affects the tooth stiffness by more than 60%. So whenever you have the chance to preserve a marginal ridge, it's of extreme importance. The next thing that Dr. Abd El-Rahman already mentioned was the pericervical dentine. We know now it's 4 millimeters above and below the alveolar crest. But here I want to highlight a property which is unique in the design of the EdgeEndo file, is that the edge file, whenever the diameter of the file reaches a 1 millimeter diameter, no matter the size of the file or the taper of the file, it stops at this diameter and it goes to a zero taper. To clarify this property, here's an example. This is a regular constant taper 6 rotary file, and the other file is the EdgeEndo rotary 6 file. Both files have the tip size of a diameter 30, which is 0.3 millimeter. So we all know with each 1 millimeter increase, we have an increase of an 0.06 millimeter diameter. So for example, at 11 millimeters, both files will be 0.96 millimeters in diameter. But here's what's unique about EdgeEndo is that after each 1 millimeter more increase, the diameter of the file will remain at 1 millimeter. Unlike any constant taper 6 rotary file, which will continue increasing. So at, for example, length 20 millimeters, which is an average length for any root canal procedure, the tip diameter of the edge remains at 1 millimeter, while any other file will be about 1.5, which is 50% larger than the edge. Why is this significant? Because we are talking about the pericervical dentine, so we are talking about minimal tapering or minimal flaring of the canal at the level of the orifice. So as you can see, all these cases I prepared with the EdgeEndo taper 6, but although I prepared it with the taper 6, it seems that the preparation is almost similar to a taper 4 preparation with no much enlargement or flaring at the coronal orifice, and the orifice remains centralized inside the canal without affecting the pericervical dentine. Next is the 3D ferrule. We all know about it, a circumferential 2 millimeters vertical and horizontal dentine we need to preserve. Finally, the soffit. The soffit is the area of the roof, the pulp chamber roof that usually have the pulp horns behind it. The idea of preserving the soffit is that you may reach your straight line axis without removing it. So if you can imagine like this diagram, by removing the soffit, you will cause like gouging circumferentially all around on the lateral walls of your chamber. So if you have a chance to preserve it and still have your straight line axis, it may preserve lots of dentine. Like for example, in this case, I had the lower second molar. I didn't know from the beginning if it's only 2 canals. So maybe if I know from the beginning, from a cone beam CT, I would have preserved this shaded area. But again, since you don't know, you don't have a preoperative cone beam CT, you can't risk leaving a part of your roof just to be minimally invasive on the expense of a hidden anatomy or a missed canal. So just maybe if I have a preoperative cone beam CT, I would have thought of preserving it to preserve dentine. So now going through the minimal invasive strategies, I believe that minimal invasive endodontics starts early from diagnosis and treatment planning, as well as access cavity designs and root canal shape. Because early from diagnosis, this young boy had an immature apex. Maybe it's not obvious in this X-ray. He had an open apex of an upper 7. So just giving the chance of a vital pulp therapy for this case is a sort of a minimal invasive approach by avoiding root canal treatment. And thus, from the beginning, you should apply your rubber dam if you have this choice. So that's what happened in this case, and we didn't need to do root canal treatment at all. Another case is this young girl, 7-year-old with an exposed lower first molar. We made, it's obvious, it has almost half root completion only. We made an MTA pulpotomy under general anesthesia. And in 18 months follow-up, it's evident that there is a proper root formation. So again, knowing how to deal with such cases from the beginning is of extreme importance. Studying a preoperative X-ray is important, not just jumping into the decay and starting root canal treatment. Like this case would probably need extraction if you did so from the beginning. So diagnosis and treatment planning is really important. Access cavity design, I won't go in details. We already now heard a lot about it, but we now know that there is a traditional access cavity, a conservative access cavity, and ultra-conservative access cavity designs, namely the ninja access or truss access, or what's called orifice-oriented access cavities. There is also guided access cavity, which utilizes the same idea of the surgical guide of an implant. And it's useful in cases of anterior teeth with calcified canals, because the guide guides your drill to go directly into the root canal space without damaging your tooth structure in the search of your root canal space. So what's my opinion in this conservative access, or what do I usually do? I believe that we should know the facts and then find our balance, or like Professor Gambarini said, try to be rationally invasive. So our first fact is that access to the root canal system is the first and the most important phase of any non-surgical root canal procedure. The other fact is errors accumulate during procedures. So if the desire is to be minimally invasive, will lead to an increase in the rate of procedural errors, such as missing a canal or creating a ledge or separating a file or incomplete root canal decontamination. The benefit will then be outweighed with our poor outcome and will lead to failure. Like, for example, this case was referred to me with a broken file in the distobuccal canal of an upper 6. Just by careful evaluation of the preoperative X-ray, I noticed that there was no straight line access for the distobuccal canal. It's evident that there's no straight line access here. And my other observation was that the file seems to be slightly of a larger diameter. It's a little bit large file diameter, and it's separated coronally in the canal. So this means that I was pretty sure that failure here was due to cyclic fatigue failure and not torsional failure of this file. So simply, just by creating a straight line access at the distal canal, distobuccal canal, the file truly came out with just irrigation. So errors do accumulate during procedures, and access cavity is extremely important at the beginning. One more fact is that detection of MB2 canals was found to be 60% in traditional access cavities, a little bit less in conservative access cavities, and only 30% in the ultra-conservative access cavities. So my idea is that to provide or to create a proper minimally invasive access cavity, we need at least 3 important things. Number one, a preoperative cone beam CT, just to avoid missing any hidden anatomy or anatomical variations. You need proper flexible rotary files with high cyclic fatigue strengths, and that can be pre-curved to enter such curvatures in a tightly access cavity design. And finally, you should have a proper ultrasonic instruments and proper experience how to clean properly the pulp chamber from pulp tissues if you're going through with an conservative access cavity design. How often do we usually have this option? How often do you encounter such perfectly sound molar, so you can choose to be conservative or not? Maybe you can encounter this with a periendo lesion, maybe in trauma, maybe in a molar that needs an intentional root canal treatment, or if it's over-erupted, for example. But that's not our usually daily practice. We usually don't have the choice. So maybe this case is a little bit extreme, but what you should do is do your best to preserve the tooth. Now, going through root canal shaping, again, starting with the facts, it's a fact that no matter the size of your apical preparation, it is not possible to render your root canal entirely free of bacterial contamination. We never get 100% clean canal. I'm talking, of course, in necrotic and infected canals. The other fact is that increasing your instrument size to sizes 25 or more will allow for better penetration of irrigants to the apical cert. So now we have a debate. Our first debate is that minimal apical preparation preserves more dentine, while larger apical preparations will allow for better bacterial reduction. Our other debate is that minimal canal tapering preserves more dentine, but over canal tapering or over flaring will provide better plugger fit or better condensation for your gutta percha and better irrigant flow on the expense of removing too much dentine. But now we have solutions by, for example, using the new 3D finishing instruments. These instruments could allow you to do a proper root canal shaping with a minimal amount of dentine removal without aggressively removing dentine, because they help too much in irrigant activation and help the irrigant to reach the apical third and they touch more surfaces in the root canal space. So now you can do a minimally tapered canal using these endo finishers as well. And about the other debate now with the bioceramic sealers, there is no need for over flaring or over tapering of the canal, because now there is no need for a plugger to fit or no need for a condensation of gutta-perca. So if you have the proper armamentarium, you can be rationally invasive. For some instances, I usually, for myself, go for directly a minimal tapered preparation, such as curvature. We talked in details about curvature last week. So quickly, again, we categorize the curvature by its angle and the radius of curvature, and also the position of the curvature. Because the more coronal the position of the curve, the more difficult the case, and the more stresses are on the file, because a larger part of the file is beyond the curvature. So larger stresses are on the file. So in such cases, I go directly for a taper 4. I never think of a taper 6. What was funny about this case, it was the same patient. He had his upper right and left second molars. It's almost the same anatomy. So in such coronal curvatures, as I mentioned, I go for safe taper 4 preparation, minimal preparation, and of course with a proper pre-flaring coronally first to allow straight line access. And in the palatal canals, in this case, I went for a taper 6. And also in anatomical variations such as extra canals or extra roots in premolars, usually these extra canals are a little bit tighter, so no need for excessive tapering or excessive preparation. I always go for a taper 4. I never think of a taper 6, to be also safe and avoid any iatrogenic errors. Whenever you have a chance to bypass a broken file, it is considered a minimally invasive approach, because bypassing a file is always less aggressive than retrieving a broken instrument. And there is no dentine damage, root canal dentine damage, as we do in the retrieving a broken file like a bypass. So whenever you have the chance to bypass, you should go for it. It's considered a minimally invasive approach. So as a conclusion, teeth may fail due to biologic reasons or functional reasons. So focusing too much on minimally invasive techniques may lead to a higher rate of procedural errors, and benefit may then be outweighed by poor clinical outcome. And also focusing too much on eliminating bacteria from the root canal system may often come at the expense of sound coronal and radicular tooth structure. So you should strike the right balance between minimal and traditional invasive preparations. And you can only do so, again, with proper magnification and ultrasonics, because magnification allows you to see hidden anatomy and deal with root canal space, even in conservative access cavities. And if you are lucky enough to have a microscope, you should see, like in this case, a lower second molar. The distal canal seems perfectly simple and single canal, but upon magnification and higher magnification, there is a deep apical split in the distal canal. So with your pre-curved flexible rotary files, you can easily do so. So our second most important thing is using a flexible night-eye rotary files with high cyclic fatigue strength and with the ability to be pre-curved, like this, my beautiful EdgeEndo file. Its firewire property makes it easily pre-curved, and once heat is applied, like during sterilization, it returns to its original shape. And finally, especially in difficult cases or anatomical variations, having a preoperative cone beam CT will allow you to go directly through the pulp chamber at the locations you can see without destroying too much tooth structure in difficult anatomical variation cases. So that's it. Thank you for your time and for your attention. I hope it was a useful presentation. Thank you.
Okay, thanks Nader for this amazing lecture.
Thank you, Dr. Ahmed.
I think you are in love with premolars.
Yes, I am.
A lot of difficult premolars. I think it's more difficult than molar cases.
Yes, I believe it's more common now to see these premolars.
Now we'd like again to announce about the Henry Schein products will be soon in Egypt, only at Perfect Dent. And a lot of people asked us to see again the interview with the Dr. Charles Goodis, CEO and founder of EdgeEndo Experts. So let's remember together this small interview.
Can you give us an overview of EdgeEndo's leadership in the industry and what makes your product stand out?
Design and also our heat treating method. We've spent a lot of time trying to create geometrically the best instruments out there, and then our heat treatment process allows it to be the most flexible and what I believe the safest instruments in the industry.
And can you tell us about some of your key products? How do they work?
Yeah, our favorite products are the X7, then also the Edge Taper Platinum, and then the Edge One Fire. They've been incredible endodontic instruments for everyone in the industry, and they're helping patients and dentists do the best they can.
Oh, excellent. And Chuck, how do dentists benefit from using your product line?
I think the flexibility and what allows them to do the best work that they can do in a quick and efficient manner for the patient.
Right. And what about the patients? How does EdgeEndo, how does that improve the outcomes for people who are undergoing dental treatment?
Our costs are probably half to a third of everyone else's, and that saves money for the dentist and it helps save money for the patient.
Great. Chuck, how does EdgeEndo ensure that each product is of the highest quality?
There are numerous, up to 20 different checks to make sure that our instruments are fantastic and perfect, what we believe every time.
Great. And so we're used to premium products coming with high price tags. How is it that EdgeEndo is able to keep the costs down for dentists?
Unfortunately, in the industry, there tends to be a very, very high markup, and I didn't want to do that. Being an endodontist, treating patients, seeing how high the costs were, we can still offer a great product, but at a half to a third the cost. We just don't need to charge as much as everybody else is.
Okay, thanks Dr. Charles Goodis for this revolution in the endodontic field by the EdgeEndo files. Now we came for the last part of the webinar, which is a discussion about our topic today. I will start with Professor Gambarini. Here's the first question. Is the total elimination of bacteria, Dr. Gambarini, how or which irrigation protocol do you recommend in such cases?
First of all, it's very, very unlikely that we can eliminate all the bacteria. There's always bacteria in the tooth, but we have to significantly reduce the bacterial charge to make it, non-pathogenic. So my protocol is slightly different. I divided my irrigation protocol in two phases. Phase number one, when I'm doing the instrumentation, and phase number two, after I finish my instrumentation. When I doing phase number one during my instrumentation, the only secret is that the files brings the irrigant. This is very important for the people to understand. So the more you can add the irrigant, the more this irrigant will be brought by the file inside the canal and deeper inside the canal. So actually this is very frequent irrigation, and it's syringe irrigation. You just put the irrigant in the orifice, the instrument will bring it in. But you do not have to irrigate each instrument. You have to irrigate more frequently. This is what I do. I go 1-2 steps inside the canal, then I irrigate with the same instrument. Then a few more steps, I irrigate again. Because as I showed last time, when the instrument cut, they cut quite a lot of debris. and this debris remain inside the canal. Only a few are removed by the instrument, so you have to clean more. So this is during the instrumentation, and this is I'm using only sodium hypochlorite. And at the end, after the preparation is finished, we also have to be aware that there are some areas that are not touched by the instrument, some areas that we were not able to do a perfect three-dimensional circumferential filing, some area we could not get, lateral canals, isthmus, or whatsoever. Now, in this case, if we have an enhanced irrigation technique by using laser, ultrasonic, sonic, whatsoever you want, I mean, but actually you need some activation. You cannot do all the endodontic treatment using only syringe. That will not be so effective, especially in the second part.
Okay, thanks, doctor, for this great answer. Okay, Dr. Abd El-Rahman, according to your lecture in the access part, what do you think the sparkling factors should you take care of?
Regarding to access cavity?
Yeah, what are the sparkling factors should you take care of, especially in your access cavity?
Yes. Doing access cavity, according to the cases, a lot of cases came to our clinic with more destruction of the two structures, but if the cases were small, I will try to be minimal access cavity as much as I can, or case-driven access cavity, and of course with hand files or same files, I can control the shaping from this small axis.
Okay. Dr. Nader, about the structural integrity of the tooth, does any root canal treated teeth or tooth need crown?
That's a good question. We used to believe always that root canal treated teeth are much brittle because of moisture loss. And I guess Dr. Abd El-Rahman mentioned this in his presentation. Studies proved that moisture loss is only 9%. So actually, root canal treated teeth function as well as vital teeth. So it's not about root canal treatment itself. It's about the amount of decay and the amount of tooth structure lost. For example, number of marginal ridges lost. So I guess it's always important to consult with your prosthodontist if there is, and you should analyze patient's occlusion, how the tooth functions in his oral cavity, and you should take proper decision together. So of course, not any root canal treated teeth should be crowned.
Okay, this is a very difficult answer. We have problems here with our colleagues.
Yes, of course.
Okay,
Professor Gambarini. If I may say something about this, because
yes.
Sometimes I have my co-workers in the office, and since I'm unluckily the oldest one, I see my cases, maybe 30-year-old cases, 25, 30-year-old cases, and some of them we know crown, and they're still there. The endo was good, the restoration also was good. So actually, it's a matter of many other things. Also the occlusion, also sometimes the lack of the patient. So it's I don't think it's so difficult to give general rules by saying this. So I think that the people should consider the post-endodontic restoration as something which is affected by so many factors that they cannot give a proper answer at that very moment, because it's a long time observation period, too long. The only thing is I recommend is that when you are in doubt, be a little bit more aggressive, say radical, because the risk is that there will be a fracture, especially if you leave some small or thin part of dentin and enamel, that would be a dramatic fracture. So what you have to, in my opinion, what you have to avoid is dramatic failure. Then whatever you do, it's fine.
Okay, that's great, Professor. Dr. Abd El-Rahman, how these minimally invasive endodontics could be applied in pulp therapy, like pulpotomy or adult pulpotomy or pulpectomy?
Actually, for the side, I do adult pulpotomy or vital pulp therapy. In such case, I extend my access cavity to allowing putting the calcium silicate material or to controlling the bleeding. So in such cases, will be minimally invasive. I don't make an access cavity small as much as I can. I extend the access cavity to be conservative, not to be minimally or rationally, as Professor Gambarini said. So traditional access cavity in such cases or conservative access cavity is the best way to manage such situations.
Okay. Dr. Nader, you told us in your lecture that you did cases by taper 0.06 and other cases by taper 0.04. What do you think? Do you prefer?
Well, actually, I usually prefer in straightforward cases, straight canals, large canals. I go for a 6% tape. I believe usually for better irrigant flow, even if you have irrigant activation and so on. If I have a chance to be almost 100% sure that I will be safe with the 6% taper, I go for it. But as I mentioned, for certain cases from the preoperative X-ray or different anatomies, curvatures, and so on, I from the beginning go with the taper 4. So it's usually the decision I take after scouting my canals with a K-file 10 and take like an impression of the canal, and then I decide.
Okay. Professor Gambarini, regarding obturation, which technique is easier for you in this minimally invasive approach?
If you want to be minimally invasive, I suggest you to use bioceramics cold hydraulic condensation technique, because this is a totally different way of approaching the problem, as the material is the sealer, is not the gutta-percha. The gutta-percha only acts as a vehicle and also as an hydraulic carrier works. So it makes no difference if you bring the cone 0.5 millimeter, 1 millimeter, 2 millimeter, 2 millimeter and a half short from the canal. So you may decide to use a 0.2 cone, 0.4 cone, 0.6 cone. It doesn't really make too much difference. What the difference is the sealer, and the gutta-percha only acts mainly, I told you, as a sort of hydraulic carrier, but mostly you can also activate with a lentulo or whatsoever, but it also acts as a path for retreatment. So in this case, you don't have to be thinking about the tag back, because one of the problems when you do a minimal invasive technique that you may have a lot of interference, so the cone may have a different tag back that you don't really get. So if you avoid the tag back and you can do with the single cone technique, that's way better.
So, Professor, you prefer high flowable sealers?
No, what I'm using, I use in my cases, most of my cases, nowadays I'm using the BC sealer, and the BC sealer is bioceramic sealer, which is, it can be used with both cold and warm technique, but I'm using mostly on cold techniques because it's much easier. And the gutta-percha cone, well, actually I use the BC sealer cone, but you could use any other cone, no problem.
Okay, Dr. Abd El-Rahman, we have a difficult question here. How could you find your extra canals, or you deal with the pulp stones or calcification and perforation in your minimal invasive approach?
Okay, it's a tough question. By using magnification, you can manage your tooth or your case, but in some cases, we need to extend our access cavity to searching for the extra canal, especially when the patient came with CPCT or preoperative radiograph showing the variation in the morphology. So in some situations, I extend my access cavity. There is no standard for the access cavity or special access cavity. Access cavity, it's modified according to the situation of the caries, the situation of the tooth, the situations of the number of extra canal. But by magnification, you can handle such situation by saving more tooth structures as much as we can.
So your answer is magnification. Whenever
Yes.
you have a magnification, you will do what you want.
Yes.
Answer.
Can I add something
Yes, of course.
to this?
Of course.
Well, no, because this is, I think, a very important thing to teach people. If they don't have a magnification. For example, I have a cone beam that helps a lot. I also sometimes have dynamic navigation technique that helps a lot. But this is a little bit too complicated. What I want to say, and this is very important, but let's forget about this. Let's give a clinical help for the people who are listening to us. Now, the very important thing is that when you have a calcified canal, a calcification in the pulp or a calcification in the orifice, it happens that you can see this very clearly with a cone beam, that the canals moves from the original position to a more external position. So it goes a little bit more closer to the external part of the root, a little bit more closer to the cervical dentin. So actually, there's no other way to enlarge the assessed cavity trying to find the canal. If you want to be conservative in this case, you may not find the canal, and you could more easily perforate, for example, the furcation rather than to find the canal. The problem because of this anatomy. So you have to always have this in your mind.
Okay, Dr. Nader, this question is for you. As an old user for the Edge files for more than 7 years, here's the question: can you substitute the glide path with 17.04 or 17.06 in your sequence?
Yes, I actually do so. So my regular sequence is I take an impression of the file, the canal with the file K file 10. In case of straightforward and simple canals, I go directly, of course, after orifice modifying. So I go for printing the canal with the K file 10 and then modifying my orifice with an orifice opener. And after taking my working lens, I go directly with the file 1704. I consider it as a replacement for a rotary glide path, but only in simple cases. Usually in difficult curved canals, I complete manual glide path, file 15, and then go forward with the 1704. But yes, it's a brilliant file. Yes, it's true.
Okay, as we always hear with files, you will never feel the difference until you try it. And you tried a lot, Nader.
Yes, true.
Okay, Dr. Abd El-Rahman, can you perform any other root canal procedures like MTA, apical plug, or epixification, revascularization?
Through minimally invasive axis cavity?
Yeah.
Yes, it's too difficult. It's too difficult. No. In such situation where I go for traditional axis cavity, as I say, or conservative axis cavity. But in such situations, MT apical plug, epixification, guided tissue regenerations, in all of that, it's so difficult through the minimal invasive axis cavity.
Okay, Professor Gambarini, how flexible shaft and edge files help you to reach your goal in minimal invasive approach?
Well, not always in minimal invasive approach, but in every curvature. I mean, I think that nowadays there is a big difference between traditional file and Martensitic flexible file. There are two different families or categories of files. So we have to clearly understand that what we can get with this file, with the X7, the Martensitic file, you cannot get with traditional file. So, I mean, the flexibility, the resistance inside of a curvature, that's way bigger. If I have to say something, is that the torsional resistance is similar in both files. It could be slightly a little bit more efficacy for an austenitic file because it's more rigid. But what I do, usually I slightly, if I think that my Martensity file is too ductile, is too soft, especially when I do with calcified canal, I slightly increase the speed, which makes it more more efficient. So actually, I think that's when you deal with a curvature, if you use a Martensity file, you go to instead of a curvature with a SUV. Otherwise, with traditional Matai, you go with a normal car, and it won't go so nicely inside a complex road. Yeah. So you need something more specific.
Okay, Dr. Abd El-Rahman, regarding cleaning and shaping, up to which size you can enlarge and shape a canal enough?
Actually, I finished my preparations at 25.6% or 30.4%. With the tip of needle, 27 gauge or 30 to reach to the shorter than working length 1 or 2 millimeters. In some severe curvatures or some severe cases, curvatures, I maybe finished this canal at 25.4%, but in most cases 25.6% or 34%.
Okay, here's our last question for Dr. Nader. Do we need post and core? You said that crown maybe there's a debate about, but what about the post?
It's also still a wide topic, as Dr. Gambarini mentioned. There are lots of debates about using a post, whether metal post or fiber post, or not using a post at all. It's about cracks, it's about preserving pericervical dentine, it's about bonding. So it's also, you can't find a clear-cut answer. It's a highly debated topic, and I always prefer consultation in such cases with your prosthodontist if you have prosthodontist.
Okay,
no,
I think one day we will.
The only thing I want to say here is that what I found sometimes stupid, also in internet, I saw cases of minimal invasive truss cavity through composite, which is meaningless. I saw minimal invasive cases that then are restored with post and core, which is meaningless. So actually, I think is in these cases, I think that first you should decide with your posthetician, because I mean, if you want to make a post and core, actually, what I do, I just take away all the cusp. I don't care because he will take away later. Why shouldn't I do this now? So this is something that people never says because it's not very fashionable to speak about being very aggressive. But actually, if someone is so aggressive after you, there is no reason why you're not aggressive at the very beginning. It makes your life much easier.
Okay, thanks, Professor Gambarini, for this webinar, and thanks, Dr. Abd El-Rahman Hamouda. Thanks, Dr. Nader, and we have a guest now with Dr. Abd-El-Rahman who was with us in this webinar. Thank you to Dr. Mohammed Ala Fakhr that we have a proper connection with him. I would like to thank you all for this event, Meet the EdgeEndo Experts event, for the first time here in Egypt at Perfect Dent, and we hope to meet you, Dr. Gambarini, soon and accept our invitation again to see you in one of our conferences in Egypt after COVID-19 issues. It will be our pleasure, Professor. And I would thanks. I would like to thank all people who shared us the success of this event. along 2 days. The first webinar with the last week, and the second webinar. Here we come to the last part in our event, which is the winner of the 5,000 Egyptian pound voucher from Perfect Dent. Here I will take paper and know who is the winner. The winner is the Dr. Al-Sayed Muhammad Al-Sayed. Please write your name in the comments now. And I would like to thank EdgeEndo, and I'd like to thank Henry Schein. And stay tuned for more surprises here in Perfect Dent. See you soon. Goodbye.
Bye-bye. Ciao, ciao.
Bye-bye.